Hello, everyone. We're on our second session for the webinars for CELG. As a reminder, CELG is the project from Global Fund, and it focuses on sharing our knowledge and lessons and experiences from the past COVID-19 pandemic, and we're trying to build on those experiences and lessons. So for the second session, these are our objectives. So the purpose of the second webinar is, one, to provide the participating organizations a platform to share, one, the challenges and gaps they encountered in the administration of programs and in the delivery of services, particularly for strengthening the engagement of key vulnerable populations and last mile populations due to the pandemic, and to the responses initiated by their national governments to manage the pandemic. And two, to share the lessons learned with regards to preparing their organizations for pandemics, particularly in the aspects of program management and service delivery, particularly those related to strengthening KVPs and LMP engagement and participation. And lastly, to share recommendations based on the lessons on the following: strengthening organizational pandemic preparedness, and strengthening the key vulnerable populations and last mile populations capacities to engage and participate in pandemic governance at different levels of government, including the national level. So for this session, we will have three parts. The first one is to describe the actual and potential scope and programs and services available to your networks of participating organizations. So for that, we will be having Jeff to discuss with us a result of their 2019 study before the pandemic, or 2020 study before the pandemic, to discuss what were the services available to the network in the Southeast Asian region before the pandemic happened. And then after his presentation, we will be having presenters from three countries: one from Indonesia, one from Sierra Leone, and one from Nigeria, to determine how these services that are available to them and the services and programs that they deliver were affected by the COVID-19 pandemic. For the last part of our webinar today, we will be discussing, based on your experiences, the lessons and recommendations on how you will develop organizational resilience, including strengthening the capacities of KVPs and LMPs for program administration and service delivery and participation in pandemic governance. And lastly, we will be summarizing the lessons to see how to move forward during the next, how we will be able to move forward to ensure that our organizations will be more resilient in terms during pandemics, and how we can best participate in the governance of pandemics at the level of the national and subnational levels. Do you have any questions for this session? None? If none, then I would just like to remind everyone that these webinars are part of the bigger CELG project, and a part of that project is the website. Just to remind you, and the website has the recordings of our sessions, some of the basic documents that might help us and guide us in terms of developing the resilience of our organizations to participate in pandemic governance, especially for key vulnerable populations and last mile populations. Then we also have discussion forums to supplement or to complement our discussions during the webinars. Jeff posted the website on our group chat in Zoom. Are there any questions? If not, then maybe we can proceed with the first presentation from Jeff. So Jeff will be presenting the result of his studies of APCASO regarding the services available for their partners in 2020. This is to give a baseline on what services were then eventually affected by the COVID-19 pandemic, and the necessary management interventions that was done at the height of the pandemic. So I will give the floor to Jeff now.
Thanks, Jerry. So what I will be presenting is this was a report that we produced in 2020 at the height of the lockdowns and the COVID-19 related measures that has been introduced in many different parts of the world. I'm going to tackle less on the kinds of services, but rather the effect of COVID-19 related measures on the service delivery. That's one. The second is in the participation of civil society organizations and community-led organizations in the context of Global Fund funding request process, and also the implementation of the Global Fund grants, mainly around service delivery, and also outreach to an extent. Okay, so what you see in the screen, on the left side of the screen, is a word cloud of the report that I will be mainly referencing for this presentation. You can have access to the report using the link at the bottom of that screen. Later, I will show towards the end the front page of that report so that it will be easier for you to find. It is available on our website. Just type in COVID-19 or rapid assessment, and you can easily find our report. So looking at the word cloud on the left side of the screen, what really comes out glaring in that report are the following words: Global Fund, health, COVID-19, civil society organizations, flexibilities, information. Malaria came out really strongly. You'd see HIV there as well, key population-led, and populations. So in this presentation, we will revolve around those different concepts and terms, and I will be mentioning all of these words. I also see some words there, such as online, migrant, and community-led. So these are some of the topics that we will be discussing in this presentation. As of the 31st of October, today, 2023, there have been around 771 million confirmed cases of COVID-19. And even if COVID-19 has been declared as not a pandemic anymore, not a health emergency anymore by the World Health Organization, the deaths still continue. And as of today, there's around 7 million confirmed deaths. But we all know from different studies and other reports that there's an excess mortality of 3 million on top of the confirmed deaths for many other reasons, mainly because of underreporting, and mainly because during the height of the pandemic itself, the reporting of deaths really took a toll, given that we really have to figure out a way immediately on how to respond to the outbreaks and the number of infections at the time. Even if WHO declared that COVID-19 is not a health emergency anymore, up until today, at least in Asia Pacific, looking at the Western Pacific and Southeast Asia Pacific regions, we still have 77 cases a day, no? Or around 28,000 new cases for every year. In the context of this report, like what I mentioned earlier, there are two processes that have been taking place when the report was conducted. So we did collect the data from this report around April to September 2020. It's really the height of the pandemic. And there were two important processes that were taking place at the time. The first one was when COVID was declared a pandemic and a health emergency in March 11. The Global Fund announced $1 billion support for COVID-19 response. And they provided a guidance for its utilizations, 50% procurement and then 50% flexibilities. Meaning 50% has to be for procurement of PPE and other related medical services, no vaccines at the time. The other 50% would be to mitigate the impact of COVID-19 to HIV, TB, and malaria services, extension of other implementation-related activities from among the Global Fund implementers, and support for social mobilization and advocacy to an extent. But this hasn't been utilized as much during that time. The second is that during the particular year of 2020, the Global Fund is undertaking its Grant Cycle 6 funding request process. So it really was the height of the funding request process, and many civil society organizations were already busy and in the middle of the grant, the funding request development when COVID-19 was landed in many countries. So given those two contexts, the report aims these four objectives. The first one is to assess the impact of COVID-19. The second is to document what has been the engagement of communities in COVID-19. The third is to understand what has been the challenges, particularly in participating in Global Fund related processes during the time. And the fourth was to seek perspectives and also see what kind of guidances can be developed at the time. No? So this is more of a retrospective at this point, given that this report was conducted 3 years ago. So who are the respondents from the report? We were able to gather 22 respondents from 14 countries. You can see the list of the countries on the right. We also developed 2 tools. The first tool is an online survey composed of 28 questions capturing the objectives of our research. It's a mix of closed and open-ended questions. And then we also conducted focus group discussions among these different countries that we've also conducted virtually. So in terms of the results, in terms of the kinds of COVID-19 measures that were put in place, the organizations and also based on the FGDs identified these 5 measures. So most of them identified lockdowns, but of course, and as we all know, there were also quarantines that were introduced. If one within the household or an entire family would be infected by COVID-19. Social and physical distancing have also been introduced, including mask wearing, and in other countries, wearing of face shields as well. Many offices have been closed down, and any reason for people to gather has been dismissed. There were also restrictions in terms of movement. So anything cross-territorial or cross-country or interprovincial travels are not allowed, and without any prior consent from the authorities, and also the curfews were in place at the time. Because of these COVID-19 measures, these are some of the impact that were identified by our respondents. So there's really a disruption in terms of the continuation and access to services, mainly on HIV, TB, and malaria. So for HIV, access to antiretrovirals and PrEP were disrupted. Many people were unable to go and have access to their ARVs at the time. And because it was very rapid, the lockdowns and the curfews were rapid, many people weren't ready with their stocks of ARVs. Same goes with tuberculosis as well. In malaria, many countries suddenly have had no access to nets and also to treatment as well. And this has really impacted the number of people dying from malaria at the time. Because of the distance as well, and because the outreach has also stalled at the time, many of the communities weren't able to have access to nets. Treatment hubs have been closed, or their operating hours became shorter, mainly closed because of the infection that has gone around during the time. Some have opened if people were able to travel from their residences to the clinics, but in other countries that were identified, some of the clinics have been repurposed either as health facilities to become COVID-19 facilities. Even NGO offices have also been repurposed to become one-stop shop for other services beyond the usual services that are being offered. For example, provide provision for food support. There was also an observation that there's an increase in gender-based violence. So requests for telehealth have also increased during the time. In terms of the kind of work that has been affected among civil society organizations, the respondents said that at least more than half said that their programmatic work has been severely affected by COVID-19. 70% of those who responded said that they are civil society implementers, whether a PR or a subrecipient of the Global Fund, but their operations have been put on hold due to an outbreak within their office space. 80% of them said that they have been involved or repurposed their work towards COVID-19 programmatic work. Here are some of the examples of how these reprogramming have happened. So in India, for example, some of their internal resources have been allocated to COVID-19. They have to work with their funders to be able to secure additional funds or some of their existing funds to support COVID-19 efforts. In Pakistan, they established this emergency response cell. It's a hotline, a response hotline, and a response mechanism wherein our partner in Pakistan would be deployed to areas and households that would need immediate TB or HIV drugs or food support or services related to responding to gender-based violence. In the Philippines, apart from reallocating some of the resources to COVID-19, there were also advocacy-related and lobbying with the Ministry of Health to push for multi-month dispensing, and this has become effective and has become a norm actually up until now, wherein people who, for example, are in stable condition for HIV now are able to access multi-month drugs for ARVs. In terms of there's also a request from many of the community members to have access to psychological support, and this has become available, and some of the NGOs who are providing tele hotline or psychological support, an increase or an augmentation to provide mental health support and have a hotline in place for any psychological needs of community members. In terms of the number of organizations who have been affected with regards to their participation in the Global Fund, you can see on the left side of the screen the differences between the funding request process, which is in light blue, and also the implementation, which is in gray. I already mentioned earlier that at least most of the Global Fund implementers from among our respondents have been severely affected. You can see that at least almost half of the respondents. But with regards to the funding request process, half said that they were moderately affected. This was where in the introduction of virtual dialogues have taken place because of the restrictions of doing in person. But this has also faced difficulties, especially in reviewing technical documents or participation in workshops online. There's also, with regards to the implementation of the COVID-19 response mechanism funds, the additional funds, as well as the flexibilities funds, which is 50% of the $1 billion US, there's been a delay in terms of the communication to other countries, which has really affected how civil society organizations would be able to utilize the funds, given that they were in a state of emergency back in 2020. There were also fewer, apparently, prevention messaging on COVID-19 that has gone around, and our partners needed those information to be able to translate them into materials that they can actually use for COVID-19 prevention messaging, but they were unable to do so. So given those snapshot of the results from the report so far, we were able to identify 6 recommendations. So the first 3 focuses on the Global Fund and funding partners to provide specific allocations to support COVID-19 community-led responses. It is now being utilized 3 years forward, under C19RM. The second is for CCM and Global Fund country teams to immediately roll out guidances and policies. Eventually, there were C19RM related guidances that have been developed as well. And then the third one is for technical partners such as UN agencies, Stop TB Partnership to develop further modeling exercises and situation reports and proposed recommendations. We saw that during the first and the second year after 2020, some of the modeling on the impact of COVID-19 with regards to the TB targets and HIV targets as well. And lastly, recommendations 4 to 6 revolved around or was targeting civil society organizations and key population-led communities to work closely with CCM and similar multi-sectoral bodies to fast-track immediate delivery of HIV, TB, and malaria drugs. This has transpired into some of the grants under C19RM to support those mitigation measures. The fifth one is for stakeholders, particularly civil society and KP-led communities, to develop risk mitigation measures that would sustain ongoing work. We also saw that as part of the grant implementation under C19RM already. And then the last one is for the governments to encourage exploration of including COVID-19 as well as future pandemic response within UHC framework. 3 years on, we saw how this COVID-19 specific response has transformed into the pandemic response. So it's good to see some developments in that aspect as well, and also connecting all the responses to UHC. That ends my presentation. So this is the title page or the front page of the report. You can find it on our website, www.apcaso.org. Thank you so much, and over to you, Jerry.
Thank you, Jeff, for giving that background and preview of what your organization and what the Global Fund has experienced, at least on our side of the globe. It is very much aligned with the lessons that the WHO has developed or learned from the management of the pandemic. It's interesting how while there were limitations on what you can do, I'm interested about how fast the adjustments and the interventions on your side were able, how fast you were able to implement those, so that the restrictions will not limit the delivery of the services anymore. One question would be, were these impacts on the services, do these affect you as APCASO as a coordinating body, or were these limitations only affecting the partner agencies in each country?
It did. It did affect APCASO's operations, mainly because some of our staff were stuck in their home countries or countries where they were at the moment, which of course affected the program. While some of the programs have continued online, the limitation of online programming, which includes capacity building of other partners, have really posed some challenges in terms of meeting some of our targets and meeting some of our deliverables also. And also the work environment has also changed a bit. At the same time, we have to make use of the platform that we have, which was mainly Zoom at the time, to really reach out to our partners, for example, in doing consultations or in doing individual check-ins in some of our projects on a regular basis, rather than meeting them in person. So all of our flights have been canceled at the time, apparently, and most of the work have been done online. In terms of repurposing some of our work, we tried as much as possible not to, given the limited funding that we have at the regional level. But from what I know with our partners, most of their funds have also been repurposed to COVID-19.
Yeah, given I was going to I was about to go to the topic of repurposing the funds in the programs. Were there instances of repurposing the budget allocated to you as an intergovernmental or an international agency? Was there a repurposing of the funds and the projects?
So for example, in one of the funding grants that we received, it was already repurposed for COVID-19.
Okay.
Yeah. So one of our projects is hosting the APCR, the Asia Pacific Community Rights and Gender Platform. And in 2020, we're supposed to be, as part of the platform's work, we're supposed to facilitate civil society organizations and how they can strengthen their participation in the Global Fund. But because of COVID-19, we receive additional funding for 2020 to focus on COVID-19. So it was already repurposed. We didn't repurpose it internally or requested it.
How has it affected your interaction and your the functions of the organizations that are under or are working with your organization from within the countries?
So it's
from your
less
side, from your perspective.
It's lesser meeting in person, which was difficult, especially when consultations are taking place. And the questions were mostly around how to provide support, COVID-specific support, like an economic or food, or responding to gender-based violence, rather than focusing on the Global Fund funding request. So the priority was different as well. It affected the priorities of our partners also.
Thank you. Just to clarify, and also just because it might be different from Africa, what is the function of APCASO in terms of TB or HIV and malaria?
So we are hosting this regional coalition called Activists Coalition on TB Asia Pacific. It's a coalition of TB activists and TB civil society organizations, and it has 5 priorities. I'm not going to go through the details, but mainly our TB-related work goes through ACT-AP, or sometimes we work in partnership with this regional coalition, which has its own steering committee to conduct some of our TB-related work. Most of our TB-related work revolve around advocacy, accountability, and social mobilization, not as much on service delivery.
Thank you for clarifying that. So the design for the program is to have someone working with different countries like APCASO to see how the COVID-19 pandemic and the restrictions affected their functions, and we'll try to see how these effects on these intergovernmental organizations like APCASO would affect now how services were delivered by the organizations working in the grassroots and in the communities. So for the next part of the session, we'll be having 3 presenters, one from Indonesia, one from Sierra Leone, and one from Nigeria, to see how these restrictions as well as the pandemic itself affected their own processes and activities, particularly in terms of program administration and service delivery, and also to see how, despite the pandemic, how was the engagement of key vulnerable populations and last mile populations strengthened, or if it wasn't strengthened, how was it affected? We'll have, for the first presenter, we'll have Krishna Wayar from Jarangan, Indonesia Positive. Krishna, are you ready for your presentation? Who will be presenting from Jeep? Will it be Adelia?
Hi, Jeff. Are you hear me?
Hi, Wayu. Yes, we can hear
Yes.
you.
Yeah, sorry for because I have the connection, have a problem with the connection.
It's okay.
So, hi everybody. I'm sorry, Jeff.
We'll give the floor to you now, Wayu.
Hi. Hello.
You can now present.
Oh, okay. Okay. So, yeah. Thank you. Hi everybody. My name is Krishna. I'm from the Jaringan Indonesia Positif, the Indonesian network for people living with HIV. So I will present what we're doing in the pandemic time and who we are and what we're doing with the CLG, the community engagement LMP group. So maybe can use next slide, please. Hello. Yes. So this is our organization. So Jaringan Indonesia Positif was people living with HIV network engaged in advocacy support for people living with HIV in Indonesia. As maybe you all know that the people living with HIV in Indonesia have a lot of challenges to get their services, to get our services in, like, for example, like health services, and there is still a stigma and discrimination in Indonesia. So that's what we're here for, the people living with HIV. Okay, next slide. So this is our objective. So we're doing the capacity building and empowerment for people living with HIV in Indonesia. We empower the people living HIV to take part in the process of advocating in several aspects. For example, like health, education, social, and economic welfare for the people living with HIV and their family. And then for the research and data collection, yeah, we were doing that to support advocacy workful to fulfill the needs of people living with HIV, so their needs will be heard and will be fulfilled with from the government. And then the advocacy. So what we're doing in advocacy, so we can achieve the better quality on health right and the services under the framework of human right by the upholding the gender equality and massively in the structure. Next slide. Yeah, our work, community empowerment and collaboration. Guided by the principle of JIPA, we aim to empower individuals living with HIV and the other key population by enhancing their capacity and knowledge. So, and then for the community-led monitoring, what we're doing is collaborate with local and national community, including the PLHIV peer support in the 26th province in Indonesia, to build the capacity to monitor and capture the issue and opportunity to influence the government and making improvement and making the policy. And then the community-based advocacy is what we're to create the supportive environment and removing legal barrier to access care. Using a soft approach, what we're doing is engagement in socialization, hearings, lobbying, and collaboration on national and international level. Next. This is what we're doing in the COVID-19 pandemic, a lesson learned that we're also doing in the CLG project. The community has strong solidarity to help each other. As we see in the field that before the COVID-19 pandemic, the PLHIV in Indonesia had been working together during the health crisis caused by the natural disasters. For example, like 2019 or 2018, there is a big disaster, earthquake in the central Borneo, and then we were helping our friends in the central Borneo to access the ARV, working together with other institution and other network. And then when the COVID-19 similar effort that was conducted by the community through JIP to reduce risk of COVID-19 and also maintaining quality of life during the pandemic situation, such as through the provision of IRT, through the peer support, providing cash voucher assistance to help the economic of people living with HIV and paralegal services for violence during the pandemic. And then the second one is community have initiative to drive policy change. Before the COVID-19, the disaster management guideline available at the national level, but did not specifically regulate about the HIV and STI. As the demand for the safe and friendly services, the PHIV community through JIP initiated the development of HIV and STI comprehensive services. And then in terms of the PPR movement, JIP has initiated advocacy through the multi-stakeholder forum at national level to discuss the progress of Indonesian government toward the PPPR. So this is the initiative recommended that PPPR efforts should be integrated with the disaster management Indonesia, because in the 4 cities that we were doing the PPPR project, that Bogor, Jakarta, Denpasar, and Bandung, the Ministry of Health and the provincial health office, they don't have any guideline for the upcoming pandemic, so they don't prepare for the upcoming pandemic. So we were with our stakeholder, we push and we support to working together to develop the upcoming guideline for the pandemic. And then the last one is community engagement is essential for the community strengthening. So yes, that engagement the community in terms of need assessment, like resource mobilization and public campaign, is very needed in the what we're doing. And then also the training and capacity building for the peer support and advocacy to build self-confidence and among the community to fight for the right to better access. And then the sensitization and collaboration with multi-stakeholder, such as a government, private, and a community organization, is quite essential to increase the awareness of community vulnerable and the last mile population related to the PPPR. So I think this is my last presentation. So thank you very much for your attention. There is also Anom in here. If there is any question, and maybe Anom can help me to if there any question about the PPPR study. Thank you. Back to you, Jeff.
Thank you, Krishna. It's very interesting how you discussed how the pandemic affected your work, and it's interesting how your work focuses actually on community engagement. It's very important to highlight that what you said, that even before the pandemic, strengthening the communities and the population groups capacities to provide community-led initiatives help to continue services even during the pandemic, because while restrictions are provided by the national government or the local government, adjustments can be actually made on the ground, and the adjustments are better done by people on the ground themselves. It's also interesting how you said that there was a lack of guidelines from the government institutions. I would just like to ask, in your case, how did your organization adjust to that, to the restrictions, given that there were no guidelines from the government? Krishna?
Maybe I can help to answer, Jeremy.
Yes. Thank you. Welcome.
Okay.
Hi.
Okay. Hi, everyone. My name is Anom. Based on the questions, like Bang Krishna before mentioned that the in terms of the guidelines related to the. Sorry, can you hear me?
Yes, we can hear you clearly.
Okay, sorry. So, like Bang Krishna mentions before that, uh, during the pandemic and also
Okay.
before the
So
pandemic.
sorry. So this is Jeremy and not Jeff. Sorry for that.
It's
Okay.
okay.
Okay. Let me continue. So, before the COVID, the guideline in terms of the disaster management is not concerning about the HIV. That's why the stigma and discriminations in terms of the disaster management is still happening. And in these situations, our friends in JIP, the PLHIV community, start to create the guideline itself. We try to train with the community itself, and during the training we also invite the government. And then when they during the training they realize that, oh, this is the new issues that we need to consider. So then for the next guideline, they try to put the issue of HIV becoming the topic in the guideline. I think that's a quite good initiative, because we start from the community, and by invite the stakeholder at least to be part of the observer of the activities, and then they have like changing in their value and see this issue as a priority. The same situation is also related with the pandemic preparedness. During we doing the assessment in 4 districts, like mentioned by Bang Krishna, we asked that, what if there is the next pandemic? Are you ready for that? And all of the audience mentioned that, oh, we expect there is no pandemic at all. And when we asked about whether you have things to do when there is a pandemic, and most of them mentioned that we try to avoid to discuss about the pandemic itself, because it already bring us a fear and a negative things. And then after we discuss with the other stakeholder that uh, the PPPR is essential, especially in the context of Indonesia, and then uh, we try to link the pandemic preparedness itself with the disaster management, because in under the new regulation in Indonesia, that the pandemic preparedness is one part of the disaster management. So we try to link these regulations to give the advocations to the government to focusing on the pandemic preparedness under the disaster management issue. I think that's all what I can add. Jeremiah and Jeff, thank you.
Thank you, Anna, ma'am. It's good that you highlighted how the community actually led to the development of policy, especially with AIDS-specific policies during the pandemic. Olivia would want to know how the communities were able to participate, or how were they represented in the decision-making process for the governance of COVID-19 at that time. How was the feedback and consultation mechanism done or developed? Was it community? I think in my case, my question would be, was it community led, or was it was the space or the platform given by the government, or was there an invitation from the government? Maybe anyone from Jeep could answer that. The question was posted by Olive from the group, in the group chat.
Okay, maybe I can add the other friend. Maybe we'll add more. Thank you for the questions, Olive. So in terms of the Indonesian's context, we think that government already consider the role of the community in every discussion. They have provide the space. For example, like they invite us to give some recommendation or opinion, and we also have a interesting approach because at before during the discussions we only discuss about our suggestions without any evidence, but after Jeep tried to doing evidence-based advocacy, we try to doing a community-based research, and we use this result of the community-based research to the advocacy process when the government give us the space to discuss about the issues. I think that's all from me. Maybe other friends from JIT would like to add.
Hello, is there, can
Hi,
hear? Yeah, sorry, my
we can
network
hear
is
you.
not good enough. So I think what Anom said is correct. What the members asking, that the community is a engagement in the developing the feedback and consultation mechanism in the TWG also, and then in other meeting also. I think that maybe yes.
Thank you, Krista and Anom. Olive, were your questions answered? If it's okay, then
So much. Yeah, everything was answered. I'm in a quite noisy place, but I'm following the questions. Thank you so much. The discussion. Thank you.
Thank you, Olive. For now, we will be moving to the next presenter. The next presenter will be from Sierra Leone, from the organization CISMAT. Paul, are you ready? We have Paul Brima Bangura from
Yes.
CISMAT.
Yeah. Okay. Yeah. Cut. Yes. Okay. Good morning, depending where you are. Good afternoon as well. My name is Reverend Paul Brima Bangura, the National Executive Director for the Civil Society Movement Against Tuberculosis. Basically, CISMAT is a TB community NGO that is working with community in terms of community engagement, awareness raising, community-led monitoring, and also working with the National TB Program in terms of finding TB missing cases to increase case notification. Yeah, so can you go to let's go to the next slide. Now, the objective of my presentation is actually looking at how to assess how pandemic pandemics affect the engagement and inclusion of last mile population. Limiting my presentation to the CELG context, actually. Let's go further. Now, context and background, as I have spoken, Global Fund organizations play a critical role in the healthcare delivery, especially those that are supported by the Global Fund. And also engagement of last mile population is crucial for effectiveness of these programs in terms of implementing TB, HIV, and malaria. So last mile population are very crucial as to be part of the entire process. Let's go to the next slide. Now, I am looking at how the pandemic responses affected the program management and then service delivery of organizations, particularly those that are implementing for the Global Fund. It was very clear that the pandemic, to be specific, the C-19, actually grossly affected programs management and service delivery of the Global Fund funded organizations in Sierra Leone in many ways, especially reaching out to the last mile population to deliver services. You know, I'm just going to give you two key challenges that actually affected the entire process. One of them was actually there was a decline. There was a rapid decline of key expected programmatic results. We did not prepare for any pandemic, you know. The results, the expected results were carved out, but then the outbreak of COVID-19 drastically reduced the result that was supposed to have been achieved. For example, for TB, case notification actually declined. It was very low during the pandemic period. The reason was due to fear of communities, especially last mile population, to visit testing centers because of misconception. You know, people refused to come. They were afraid to be diagnosed of COVID-19 and also to be quarantined. So because of those diagnosing, because they see the illness as something that is very dangerous for them, so that actually limited case notification in terms of TB. And there was another aspect that has to do with misconception and lack of right information sharing during pandemics. So this affected program implementation because, for example, there were misconceptions, there were misunderstanding in terms of COVID. You know, some say COVID is a man-made sickness to wipe out the people. You know, and because of that, a lot of people resist the response. You know, so the response were actually resisted by a lot of community people because of perception and misunderstanding of the entire thing, you know, and then the required information, even though it was there, but it was not trusted, you know. So basically, this is how it affected a lot of, especially vulnerable communities, you know. Let's go to the next slide next. Yeah. So challenges posed by the pandemic, like I said, disruption in regular healthcare services. You know, like I said, there was no preparedness. There was no kind of contingencies. I mean, preparedness put aside for any outbreak. You know, the health systems have their programs that was running. Once once an outbreak occur, then there was a total disruption into the regular service delivery. For example, TB, HIV, and malaria. You know, so resources were allocated. You know, resources were from
malaria, TB, and HIV were part of them were allocated to fight against COVID-19. So you see, there was a lot of kind of problems, you know. So resource allocation challenges also was a very big problem because we did not prepare for COVID-19. And of course, traveling restrictions affecting field work because of there were policies that came up because of we were trying to curb the pandemic. So traveling restrictions were very, very eminent, and that it affected especially organizations, small organizations, last mile population organizations to go right into the field. You know, next slide. It's impact of engagement and inclusion of last mile population. This reduced field visits, leading to less direct engagement. You know, inaccessibility to remote areas, limited community participation in decision making as well was also, you know. Next. Now, looking at the governance aspects, there was also a problem in terms of the pandemic response governance, in terms of program management and service delivery. Now, one of the things that we experienced, and according to the findings, there was an exclusion of last mile organization in pandemic governance. It was actually eminent. During the COVID-19 pandemic, there were new policies, you know, new policies came up. These policies were put in place to actually help reduce the prevalence of COVID-19. You know, but most times, the affected people are criminalized with short policies, you know, especially last mile population, while they are also vulnerable to the pandemic. You know, so that was like two-way. That they are criminalized because they cannot meet the required laid down policies, but also they are the most affected by the pandemic as well. So they were caught into kind of situation. You know, for example, we said the use of mask was an example, and the intake of vaccines. You know, so you see, last mile population were constrained to access short mask in most communities. You know, and in fact, some of those masks were sold. If you don't have, you cannot go out. If you don't have one, you cannot go out because they say you have to go with the mask outside to go to the market, to do other things. So some that do not have mask cannot go. If you don't have money to buy one, you cannot go out. So you see, so key vulnerable population were mostly affected, and very simple. The law can just catch them very simple. You know, so we see, we actually saw, based on the finding, that law enforcers use this this situation to do a lot of exploitation. You know, we saw people were saying they were arrested because they don't have masks. They are supposed to be given this mask free, but they were arrested, do not have mask, and then you have to pay. The police will take you to incarcerate you, and then they exploit money. So these issues actually was prevailing, you know. Is it next slide? Now, governance and adoption of emergency governance protocols, and I spoke about this, remote monitoring systems, the visual training sessions for local health workers. You know, this also is the next slide. Now we have lessons we have learned, but also we have some recommendations. We are proper now. Now the need for contingency planning. You see, that is why this emergency preparedness kind of approach is very good. I remember when we had a meeting with stakeholders, and I was asking them, what are you putting in place? And after COVID, what have you put in place? You know, you can find out that there is still
no clear contingency planning. If there is any outbreak, we will go back and affect TB funds, malaria funds, and HIV funds. I'm speaking about Sierra Leone here. You see, so there is need for contingency planning, and the importance of flexible governance structure also. For inclusion of a last mile population in terms of decision making. Recommendation: develop pandemic specific engagement strategies for last mile population. Next. I'll conclude with this one. Of course, we know that pandemic significantly impacted programs management and also affected last mile population engagement. So we need to adopt a kind of a governance and planning that will actually include them moving the process forward. The last slide. Let's go to the last slide. Okay. Now COVID-19, we know it's actually inflicted a lot of catastrophic cost. And then you see those that were actually affected are vulnerable communities, And then also the progress in the fight against TB, HIV, and malaria was interrupted. You see, so once there is an outbreak, vulnerable people are affected. The law is penalizing them, They don't have access to what they're supposed to have, So there were a lot of issues regarding last mile population involvement and then access to information, So thank you very much, and I stop there.
Thank you, Paul, for that very comprehensive presentation. It's wonderful that at least for the two past presentations, they highlighted different aspects of how they were affected by the COVID-19 pandemic. For your group, at least what was focused on was how the services usually delivered to the last mile populations were affected. I would like to ask first, what are your last mile populations, or what last mile populations do you usually work with, Paul? In terms of HIV and AIDS and TB.
Come again with it. When?
What are the usual last mile population groups that you work with?
When last do we engage with last mile population? Is that the question?
Yes. What kinds of last mile populations are you working with?
These are affected. Some of them are affected by the disease.
Oh, okay.
Form into a group. But also we have a category of hard to reach communities. We have disability, TB affect disability as well. Then we have other support groups, organizations that are actually working in support of fighting against TB, HIV, and malaria across the communities. But our focus is actually TB patient, and we're working. Our large constituent is affected individuals. We call them support groups by TB.
Thank you for
either directly or indirectly. Yes.
For the hard to reach areas, what do you mean by these? Are these people from remotely accessible or physically inaccessible areas? Is that what you mean?
Yes, they are. I mean, because of the road networks, they are very close to the borderlines. You see, very recently, our assessment, CELG assessment, we went to a district that is a new district. It's 2-year-old. No, it's 7-year-old district. It's hard to reach. I shared the picture with Rachel. You can see that our vehicle was stopped on a muddy place, so it's very difficult. So you cannot find very little, very small interventions in those locations, So these are hard to reach. So they are left out. They are cut off from a lot of welfare benefits, from a lot of health. Yes, You see, so we manage to go there and it's very far from the city. It's one of the farthest.
Yeah, given just a follow-up, given the nature of their last mile populations and the need for actually trying the need all to visit the sites, how did you adjust, especially during the restrictions of the pandemic?
Come again, let me hear you clearly.
You told me you discussed earlier how these are remotely accessible or physically inaccessible areas, and that you need actually need field work to conduct or deliver your services. How did you adjust to the decreased opportunities to travel for field work during the pandemic?
What we have done, so what CISMAT has done is to have contact, satellite contact in those hard to reach areas. You know, so once we want to do something, we just contact, and then we use the base structures that are there. So we have trained base structures in those hard to reach areas. You know, so once we have something to do, you know, we put them on board and they can do it, and then we use an online kind of conversation, you know, if we are not able to go. Because you see, during the mid-rainy season, it's very, very difficult to access those places because vehicles cannot go across, you know, because there's a whole lot of water, you know. So we have structures that we are dealing with, you know, in those hard to reach, you know. So we are everywhere. All the dot facilities, we have what we call community TB animators that we have assigned. So those are harder to reach. So once we need information, we can get those information very quick. Once we want to share information, we can share them very quick. They can reach very quick because of those structures we have trained. We are still training them to actually take up community-led advocacies, community-led monitoring, and a lot of other interventions in those
Thank
areas.
you, Paul. Are there other questions from the other participants regarding the presentation, regarding CISMAT's presentation? Do you have questions, Paul or Olive, Rachel?
I have a question, but I'm trying to look for the raised hand.
There's a raised hand. Are there raised hands? Let me see.
I think you can go ahead, Austin,
Okay. Austin, you have a question?
and then Olive on chat box.
Austin, do you have a question? Well, maybe you can go to Olive's question first. To Paul.
I don't know what,
Austin, go
whether I
ahead.
explain how.
Austin, if you have difficulties with your connection, you can type the question in the chat box.
No.
While waiting for Austin, I'll read Olive's question. Olive's question is, Paul, are these communities organized or coordinated? And what would it take for them to better participate in decision making directly?
The communities are well coordinated. They are organized. Like I was saying, every district we have what we call a district coordinator. We give them motorbikes so that they can be able to reach across communities. So our coordinators actually coordinate those communities. We have 3 types of structures that we have instituted in those communities. One of the structure is the community TB animator structure. They are actually engaged in community-led monitoring. I mean, they go to actually do a watchdog on the national service delivery community level, you know. Then also we have this TB support group structure also that these are former TB patients. So once you have been cured, there's a certificate given to you, we incorporate you into that structure. That is what we do. So it grows every now and then in our district, you know. So once we have activities, we train them. So he who knows, who feels it, knows it. It's a kind of a patient-centered approach in the fight against tuberculosis, because this is where we're focusing. You know, we also have a structure that we call community health clubs. These are community stakeholders that help us to mount community-led advocacy in terms of drug stock out, in terms of issues that are coming up that has to do with human rights violations, that has to do with service satisfaction for TB patients. So they can come up as a community arm to actually advocate. So these are the three structures we are working with in all of our districts, the 16 districts we have. So once we need an information, it's coming quickly.
All right.
So there is a kind of an organized system that is operating. That was why before we reach the hard to reach Falaba to specific, that I was talking about, that very dangerous network. We have one that organized. So by the time the team went to do the assessment, a system was set. So the DMO there was there, all other stakeholders were there, key informants, everybody was ready now to receive the team.
Hi, Paul. Were these organizations organized even before the pandemic, and then you just maximized their resources during the pandemic because of the restrictions, or were they organized during the pandemic?
They were organized before the pandemic.
Okay, noted. So
yes, they were before.
Yeah.
So it's just maximizing, every now and then it's based on the emerging issues. So we integrate those structures to emerging issues related to TB,
Yeah, thank you. So that just goes to highlight how important the networks are, how networks should be strengthened even before pandemics, and then develop flexibilities among these structures and organizations so that during times of crisis they will be able to adapt easily, and then you can maximize them. Thank you, Paul. Austin just wanted to ask if you can comment on the use of ONL Impact to reach your clients before we proceed to the next presenter.
Come again?
Austin asked a comment through the chat
On
box.
One Impact.
Can you comment on the use of One Impact to reach your clients?
Okay, yeah. It's now that we are coming to adopt and implement the One Impact with around 12. We're on the preparation now. We have actually did training on One Impact, but we have not rolled it out yet. So what we are doing, our community-led monitoring for now was using a ComCare platform that is hosted by CRS. So once those information comes into the platform, CRS can just put it in a report form and we can get it there. But now we are going to roll the One Impact 100% come December. So we use that platform moving forward for all our community CLM engagements.
Thank you, Paul. Then we will now proceed to the third presenter from Nigeria. We'll have Paul Balogun from Janna Health Foundation. Paul, are you ready? Thank you, Paul Brima.
Welcome.
Yes, I'm ready. Paul Balogun from Nigeria.
Paul, you can now present. Thank you.
Thank you very much, and greeting to each and every one of us on this call. The coordinator have actually said, my name is Paul Balogun from Janna Health Foundation, Nigeria. So today we are going to be looking at the impact of pandemic and governance on the GF-funded organizations in Nigeria, with specific focus on the program management, service delivery, and the inclusion of the LNPs. So in our presentation today, we did not actually narrow it to only the Janna Foundation experience, but actually we gathered experience across the organizations from Nigeria that are funded by GF. So can we go to the next slide? The overview of this funded organization is in Nigeria, the GF funded organization have been doing well in terms of improving the health facilities, health sector entirely. So this GF fund have actually helped towards the improvement of our health services through so many organizations. And in Nigeria specifically, we have the government and then the non-governmental organization. So both the government and then the non-organizational government have actually a key into the funded with this GF fund. So some of the critical areas that those organizations actually play a key roles, including the treatment and then support of HIV, especially looking at organizations like the NACA, National Agency for Control of AIDS, from the public sector. We have also the NEP1 network of people living with HIV. We also have the Family Health, Society for Family Health as well. So also looking at another role, critical role played by other organizations supported or funded by GF is the malaria prevention and distribution of mosquito net across Nigeria. And other organizations also focus on the TB diagnosis, treatment, and support. Organizations like ours, Janna Health Foundation, also key into this specific area of TB diagnosis, treatment, and support, as well as we have the KNCV, we have Superbell as well here. So other organizations also focus on the immunization campaign like polio eradication. And also one that I didn't actually include it here is the health strengthening system. So other organizations actually focus on that. So these are some of the key areas that some of these GF-funded organizations in Nigeria play effective role in promoting the health sector before, during, and even after the pandemic. So these are what they normally do in Nigeria. Can we move to the slide? So as they carry out the activities from several angles, COVID-19, that is the pandemic, actually come into. During the first lesson learned, we shared through the webinar here, we actually recognized by the presenter, Jeremiah, who actually quote from the WHO, that the pandemic itself, when we talk about the pandemic, we're talking about the global outbreak of diseases that affect humanity. So those organizations that are working in promoting the health sector with funding from GF do not actually prepare for these challenges that actually comes in, and for this pandemic per se. So this pandemic actually caused a lot of restrictions when it comes to movement from one place to another, not only for the members of the organization to oversee some of the projects, monitoring, but as well as movement of individuals in the nation was highly restricted. And then there was lockdown. So many people are in-house, so cannot be able to move out due to the pandemic. And if you could remember, like I said, a lot of projects we are going on before the pandemic comes in, and then the supply chain was actually disrupted across the globe, actually, not only in Nigeria. So even within the Nigerian sector, looking at the supply chain, movement of drugs, procurement of drugs was restricted because of lockdown, as well as traveling restrictions. So a lot of issues happens. So you hardly get in touch with KVPs, even patients in the facilities. So facilities are not well functional of them. So service delivery, when it comes to service delivery, so you see there is a lot of delay when it comes to distribution of medical services as well. So these actually affect a lot of programs, a lot of projects that are going on supported by GF Fund. For example, looking at Janna Health Foundation, when it comes to TB, that is tuberculosis, you see that reaching out to the community was, although we have a structure then, but it's become a challenging, especially how we can be able to move out due to the lockdown. So this becomes a key issue and during the pandemic per se. So can we move to the next slide? Okay, so some of the unique challenges faced by the GF-funded organization, specifically for those organizations, is that trying to reach out to the last mile population, including remote rural areas. So this has actually become a strong challenge, seriously, because the lockdown, as well as the restriction of movement, you hardly go in there. And there was a local participation that, for example, looking at the pandemic, COVID-19 per se, so a lot of people from the rural areas are looking at this COVID-19 is an urban disease. So when a person is coming from the urban area to the rural area, some of them are afraid to even associate because they view the person as coming with the disease in order to share to them. So this was a great challenge in trying to reach out to them. And not only that, a lot of programs was, for example, project was actually shifted from the main core funded to COVID-19. For example, looking at, we are running projects on TB, but it has to be stopped and attention has been moved to COVID-19. So those areas become neglected for a while, which actually affects some of the beneficiaries as well. So in terms of also checking up as well as monitoring activity during this pandemic was very hard because of the lockdown and then not able to do restrictions on ground. So this becomes not much more effective during the pandemic. So, however, there are a lot of innovations put in place. For example, with the Janna Health Foundations, try to come up with the telemedicine, and then yeah, but the telemedicine was not too effective because as of then, a lot of people could not be able to reaching out to the remote areas. They are not even aware of how to use those kind of services as well. So they are having less knowledge in terms of using of electronic means in order to communicate. So some places do not have network as well. So this has actually become a great challenge. So these are some of the few unique challenges faced by those funded organizations, GF organizations, not only the non-governmental organizations, also the public organizations, in trying to reach out to the last mile population during the pandemic era. So can we move to the next slide and we look at the strategies? So yeah, thank you very much. And in addition, you see, there is a high belief, from the challenges, unique challenges, there is a high belief and perception that COVID-19 is not even real, it's a human-made, so it's something that is coming up to actually take away or deal away with people. So this kind of perceptions was a critical one in time to do away with it, to reach out to the last mile population as well. So here we recommend some of the strategies that can be used. One is the utilization of the community health workers. We already have a structure on ground, but due to the COVID-19, we have to also look at the structure to make it very strengthening, especially in utilizing the community health workers. So, in different communities, we have health workers. So we try to source and link up with health facilities closer by. So through the health facilities, for example, through the TB program, focusing on TB, we reach out to the TB program, who some of those health personnel serve as supervisors, and then we now recruit community volunteers from the community who actually work in terms of promoting the activities of TB in the community through screening and other related activities within the community. So these are kind of a linkage or rather strategy we use, and then this actually work. and trying to utilize it will actually make more effectiveness. So also looking at telemedicine and mobile technology, mobile health clinic is highly effective. So, but here, if we can actually introduce it to the health workers, that is at the remote areas, who can be consultants to reach out to the last mile population closer by, because of language barriers and other things. And then so we will also be monitoring them. If this can be effective, I think it's going to be a good strategy in trying to reach out to them. And also integrating TB programs management with the COVID-19 services as well. So partnering, as we did through this program, that is the community engagement and leadership and governance, we understand that there is need also to include the community representative from the last mile community in parts of the implementations of activities within the community as well. So these are some of the strategies in order to reach out to the community. If they can also be used, especially as community mobilizers and then volunteers, it will be highly effective strategy. So can we move to the next slide? So the next slide is actually a conclusion. So COVID-19 actually become a great challenge to us, but has actually give us a way of becoming adaptability. So in terms of adapting to this, we need to build a resilience by investing much in data analytics, promoting the health education sector, and then enhancing the infrastructure of the health sectors, because some of the health sectors were lapidated only during the COVID-19. It was known that they were not even into functions. So strengthening the global collaboration we actually have here. And then thank you very much. And come to the end of this presentation. So the next slide is question and answer. So here I have the ED who is here, Dr. Stephen, as well as our consultant for this program, Olaide, who also help in adding more, as well as answering some of those questions that may come in. Thank you, and over.
Thank you, Paul, for the presentation. I would just like to clarify what kind of, just like with Paul Brima earlier, what are the last mile populations that you're working with? Are there specific types of groups that you're working with, who your services are delivered to?
Okay, thank you very much. For TB program, we focus on the IDPs, internally displaced persons, as well as the nomads. Some of our interventions, most of them are from the northeast part of Nigeria, where we have the nomads and then the internally displaced persons due to insurgency. So these two key are the last mile key populations that we're working with. Thank you.
Thank you. And then just since these are nomad communities, how were the systems developed after the pandemic? Just for you, in order for you to provide the services, aside from telemedicine, did they continue to be nomadic communities during the pandemic, or were they restricted as well?
Okay, if I heard you clearly, the nomadic communities are communities that are actually into existence. So some of them are settling within a particular place. Some of them are actually traveling. They don't normally settle in one place. So, but despite that, there are nomad chief. We have the nomad chief across states, across communities, across everywhere. So wherever those for example, the nomads are traveling, there are chiefs across. So those chiefs are there, and then they monitor, they know where they are going. So I think
thank you.
This is how we try to reach out to them. Dr. Stephen want to add more. Thank you.
Yes, thank you very much, Paul, and thank you, colleagues, for organizing this very important meeting. Yeah, about the nomadic, I wanted to comment that quite a few of them are settled in grazing reserves, but most of them, especially the middle age group, they are the ones that move with the cattle, and then they move along defined routes. And we have been able to collaborate with the respective government ministry to obtain the maps of the movement. And we also, over the years, identify strategic health facilities along those routes, including even veterinary service delivery point for the cattle. So we've converted some of these to dot centers in the past. And we have built extensive capacity among the youths of the nomadic people as volunteers. Right now, we have over 400 of them that we have trained that are able to identify presumptive TB cases, and they know what to do. They know where to refer them, even when the program and the project is not running. So this is what is happening. And again, personally, I was the incident manager for COVID-19 in the state during COVID-19, the pandemic. So we made sure that the risk communication pillar also are in the communities and working hard against those beliefs and misconceptions that affected health-seeking behavior of people. Because there was a time that anybody that is coughing does not want to go to the hospital because they will think that you're going to diagnose them with COVID-19. So that cut down the number of people that are agreeing to be screened for TB. But of course, with this support, things were picked up. Things picked up later, and yeah, they started patronizing. Yeah, over. Thank you.
Thank you, Stephen, for that clarification. That's very enlightening in terms of how existing resources already were maximized at the time for the delivery of services of COVID-19. So our time is about to end. I would just like to, are there other questions before we wrap up this session? If there are none, and I would just like to highlight, Olive has a question. What government and other multi-stakeholder partnerships have been developed to support work with the TB key vulnerable populations? I would like to ask the responses, at least from each of the presenters, if that's okay. Again, we'll go back to Kresna. Is Kresna still here? Okay, we can go back to Kresna later. We can how about Paul? Paul Brima from Sierra Leone.
Yes, come again. What's it?
The question from Olive is, what government and other multi-stakeholder partnerships have been developed to support work with the TB key vulnerable populations?
For us here, I think we have a cross kind of partnership with other stakeholders. We see more of NGO partners actually supporting the TB program. And then also the last mile population, for example, we have PIH is working very hard to support in that direction. In terms of developing strategies, we have also MSF. MSF also is part of that partnership. Then, of course, WHO as a technical partner also. So on the side of government, I think the National TB program is more active because they are actually responsible on the side of government. But other than that, we have not seen another government arm actually bringing support or supporting in terms of developing strategies. You know, very recently, we had a meeting with partners to review national treatment guidelines, and then you can find all those partners that I'm naming, the PIH, WHO, MSF, you know, and then I think SOLTES, you know, and the TB program, you know, including civil society organizations, CISMAT, you know, in that process. But I think these are the stakeholders that is actually supporting the TB strategy, you know, in terms of implementation, planning and implementation as well. Yeah.
Yeah.
Thank you.
I don't know whether I've answered the question correctly.
Thank you, Paul. Stephen raised his hand.
Yes. I wanted to say that we enjoy immense support from our government here. because of course, some of us, like myself, I work also as director, and then I told you about my role as incident manager of COVID-19. So our organization is well known here, and government supports it at the state level, at the local level. Everything we do together with the NTP, because at the local level, you have the local government supervisors always participating as part of our team as we engage the nomadic people or even the IDPs. And then there are some certain organizations also that are within those, working within those last mile population. For example, you have the Emergency Management Agency, which is working with IDP. So we work together with them. And then on the nomadic side, they have their own local organizations that they founded to support some like humanitarian services among the nomads. For example, there is one that is called Pastoral Resolve. So this is the first organization the nomadic people formed, and we had to collaborate very closely to launch the TB program among the nomads from 2010, 2011. So then we have also at the state level, there's the Partner Coordination Forum, where all the partners come together every month to discuss what they do so that the government, they're like, keep track of everything that is happening. So this ones here, we identify some other partners that are working in the same population or around there that we can collaborate. Sometimes we collaborate in terms of information because of security challenges. You know, this area is a security challenged area. So if you don't share information, there can be problem. Then lastly, we have the UN agency that we always report our activities to, the UN OCHA. So every month they send to us a form that is called 5W form. And then we always complete in terms of the number of people who reach with TB services, how many were diagnosed, how many were linked to care, etc. So these are the organizations and partners that we are collaborating with as we implement the nomadic and the IDP projects in the northeast of Nigeria. Thank you. Over.
Thank you, Stephen. Krista, would you like to, and Paul, would you like to add more?
Yeah, I think we also working with CRS is very instrumental. It's also supporting us in terms of engagement with the last mile population. You know, so I think I left them out, but they are one of our key partners that are working with us, and are supporting us and building us capacity as well.
Thank you. So as we wrap, so we're wrapping up right now. What the key highlight from the past three presenters, for me at least, was that it's important to strengthen your key community service, civil society organizations, as well as your community organizations, including KVPs, even before the pandemic. And what's important, I guess, and what organizations are learning now is, in order for organizations to be resilient in the first place, we have to strengthen our organizations internally and our networks externally, even before the pandemic happens. A key lesson that we've learned, I've learned from earlier today, from one of the presentations, is that if we strengthen our capacities to provide our service delivery, even before the pandemic, it will provide us leeway and capacities to be able to be flexible to adjust the needs of the pandemic and the restrictions related to it. And Paul from CISMAT, I've actually identified the need for contingency planning in preparing for pandemics, while at the same time ensuring that services are delivered regardless of any impending crisis. So for this session, we tried to look at what the challenges were presented to us because of the pandemic. And then we also wanted to look at how we adjusted to these challenges to learn to call out the lessons. For the next lesson, for the third session, we will try to assess how your organizations are now trying to improve on your services, and how you're trying to improve, since we recognize the importance of our key vulnerable populations. How do we now try to strengthen the capacities of our partner key vulnerable populations in terms of participating in developing mechanisms for them to participate in pandemics? So for the next session, we'll try to see how the lessons that you have learned are being applied by your organization, and for the strengthening of the participation engagement of our KVPs. Jeff, do you have anything to add?
Thanks, Jerry. Nothing to add, but maybe some announcements. So for our next webinar, it has recently moved from the 23rd of November now to the 22nd of November, same time. And it will also be a public webinar from then on. So you can always register through our website, but this time, since it will be a public webinar, you may share this now with your partners and all the other organizations that you have engaged with in your current CELG project. And then we will also share the presentations today in our next newsletter. Let me know if you are not able to receive our newsletters that I can include you in the listserv. But I hope everyone was able to receive the first newsletter.
So
Over to you.
you might have a lot more questions, especially since we're presenting now your actual experiences, and I'm sure that you removed out a lot of the details, but we're interested about the details about the lessons that you've learned. You can continue to engage using the CELG website. There will be discussion. There are discussion forums there, and we can add more topics that you can ask questions, post questions, and then give answers as well. Thank you. If there are no other questions, then again, thank you, and we'll see you during the next session on the 22nd of November.
Thank you.
Olive,
Thank you very much.
Bye-bye, everyone.
Bye. Bye.
Let me forward it to you, Olive.
Thanks, Jeff. Maybe just as you're still there, others can leave,
Yes.
but just a quick question on the newsletter. How do we get like more people getting the newsletter, even the flyer for the public one? Is it possible for us to have develop a flyer such that we're able to share it more widely? Let me just put myself on video. Other people can leave, of course, so that at least we can get more people to get to be part of this process. Also, get more people to come to the information hub, because there's so many things that we are currently doing, and I think we need to now get more people to interact with this stuff.
Yeah, we will be developing flyers, and we will also post the webinar on our Facebook. We will also be doing a Facebook Live for the third webinar in November as well. So it will be more public for the third one.
Okay, thank you so much, Jeff, and bye-bye, everyone.
Thank
Can we have a
you.
picture, please?
Bye.
Can we take a picture of the group?
Yeah, sure, sure.
Can you turn your cameras on, please? So we can document it.
Here.
Oh. Okay, we're waiting for some of them, some of the others. Okay, is this all? Okay, 1, 2, 3. One more. 1, 2, 3. Another one. 1, 2, 3. Thank you, everyone. We'll see you again.
Thank you.
Thank you.